Thank you very much. Good morning, everyone. It's an honor to be there. My name is Aleksandra Raczyńska. I'm a doctor. I'm working in the infectious diseases department here in Krakow. So my case is the case study of neuroinfection accompanied by thrombocytopenia. So our story with the patient started in 2023 in June, and she was a 65 years old female that came to the emergency department because she had fever. Fever lasted 10 days before she came to the emergency, and except the fever, she had also not very strong, but she also complained of headache. Of course, she were in the family doctor ambulatory visit, but there is no improve, and she came to the emergency department. When she, after the initial diagnosis of emergency, she was referred to our infectious disease department with suspect meningitis. The patient during admission was in very good condition. She was stable with no meningitis signs. She was fully oriented, no skin changes. We take the detailed epidemiological history. She was retired, but she generally spent time at home, but sometimes in her garden because it was June, so the weather was better than now in Poland. And we made some tests, and of course, emergency made some tests. From the abnormalities, we observed the leukocytosis, also elevated liver enzyme and elevated C-reactive protein was 112. CT scan that was done on the emergency department revealed no specific abnormalities, so we done lumbar puncture that revealed lymphotic meningitis. This is the slide that showed how frustrated sometimes the doctor life is, because we made many tests to find the etiology of this meningitis, but we still didn't know what is the etiology of these diseases in our patient. But our patient was still stable, so she was treated with fluids. We first introduced her to ceftriaxone because we think about the Lyme disease on the beginning, but when we had the result, there was negative serology to Lyme, we stopped giving this. But patient get better and better every day, and we were very happy because of this, and we plan to discharge her to home. But unfortunately, on the 7 days, the condition of the patient suddenly get worsened. So there was the duty of my friend Ola, and Ola is not so very lucky doctor. She have always busy duties, and it also was the same in this night, because during the evening our nurse called Ola that something wrong is with our patient, and her skin color changed rapidly. So Ola came to the patient really fast, and she noticed that our patient developed hemorrhagic diathesis on the skin and mucous membranes. She also had the really mild nose bleeding during this evening, and she take her the blood to analyze, and she revealed severe anemia and thrombocytopenia. The platelets was lower than 1,000. Unfortunately, during the next hours, the patient condition getting worse and worse. We observed during the next day in the morning the massive gastrointestinal bleeding symptoms. So what we done? We were on call all the time with our hematologist, and to try to find out what is the reason of this thrombocytopenia. We, of course, fight with the hemorrhagic shock. So we done blood transfusion, and when we established with our hematologist that the diagnosis of immune thrombocytopenia, we also gave the patient steroids and immunoglobulins. So when we had the time after we fight with this hemorrhagic shock, we think, what is the link between our lymphotic meningitis, our immune thrombocytopenia, and our chef told us back to the beginning. So we thought about Lyme disease, but maybe it's another disease also transmitted by tick we should think about on the beginning. And it was anaplasmosis. So as soon as we started to think about this, we gave the patient doxycycline. And she was getting improved after the treatment we gave her. We established our diagnosis with PCR tests from the blood, and the antibodies, there was positive from the blood, and we observed that the patient condition is getting improved. So anaplasmosis is the disease the symptoms of this disease are not very specific. Sometimes can be asymptomatic, sometimes give fever, headache, muscle pain, so nothing specific. And unfortunately, it's underestimated. Usually in lab tests, we observe, for the patient who have anaplasmosis, we observe leukocytopenia. Our patient have leukocytosis, so it wasn't really specific for these diseases. But also we can observe thrombocytopenia and elevated liver enzyme that had our patient. And the mortality is higher when the treatment with doxycycline is delayed. So what I want you to think, to know about from this presentation, that I want you to think about the anaplasmosis like a rare reason of encephalitis, meningitis, immune thrombocytopenia, and disseminated intravascular coagulation. There is the disease that I think in Poland especially there is underestimated. Many people think about the Lyme disease, many patients know about the Lyme disease, but I think that we are really lucky, like infectious diseases specialists, because when the patient came after tick bite to the doctor and tell about the symptoms, sometimes they are treated with doxycycline. There is also good treatment for anaplasmosis. Thank you very much for your attention.
Thank you. And now time for comments.
As you have excluded the family of my beloved herpes viruses, the next step was obvious. So you must also regard that despite tick-borne diseases, we have also louse-borne diseases, which are almost the same in transferring pathogens, except of tick bite encephalitis virus. So the step and the thinking about the vector diseases is, in this case, when something is worsened and is multi-clinically changeable and the state of patients is changing, it is a good reason to think about the travel and geographical places where such cases occur. Congratulations.
Thank you very much. Thank you. Yes, I wanted to say about this patient that we, of course, in infectious diseases, everybody, we ask about the tick bites. And of course, this patient, we also ask about this. And she told that no, that she wasn't bite. But when we asked one more time during the worsening of the condition, the daughter of this patient told us that maybe she was bitten by some unknown insects. So it was in the history, but sometimes you should take it twice to get to the answer of the question.
A very good and interesting case. I want to comment, or you can comment, about the ceftriaxone. What was the reason to give ceftriaxone?
Yes.
It seems to me, and also in my country and in my department, that it became a routine antibiotics that you give to everyone every day.
Yes, I agree with you. I even asked my chef if I should present this ceftriaxone because I don't know the reason why it was given, but my chef told me that we are not perfect, so we should tell the truth. And, probably my friend who admit the patient think about the Lyme disease because there was the season, because there are many ticks in Poland in June, and there was many patients with Lyme, so maybe when she saw the meningitis, till we were waiting for the lab test for serology from the cerebrospinal fluid and from the blood, she gave her. But when we, of course, get the serology, we stop this because we think that the patient go home, and then she get worsened.
Well, let's face it, how many in this room heard about anaplasmosis before this presentation? Hand up.
Well, we have quite a few.
I'm almost surprised, but not that many.
All right. Any more comments or questions? Because if not, we will move on. Roman?
Yep, go ahead.
Yeah. Okay. Thank you so much. Thank you very much.